My name is Bianca Nugent-White. I am the ACCEL Delaware State University representative. I hold as an honor of being an assistant professor at Delaware State University within the nursing department. And my purpose for the past 2 decades is actually being a pediatric nurse at the bedside and in research. And currently I still work at Nemours as a pediatric nurse. So when Dr. Wyndham was talking about the people that hold the arms and stick the needles in, that's me. And now, currently, in the past 5 years, I'm the one who actually teaches new nurses how to do that safely and doing research in how to actually make that a less painful experience. Okay. I have also the prestigious honor of introducing our next moderator, who happens to be a Delaware State University faculty member. And for the past 5 years since I've been a professor, she's kind of been more of a phenomenal, seeing her resume that one day hopefully I will be able to accomplish. And it's funny, I'm actually looking at her right now. She's probably like, oh my gosh, it's a little nerve-wracking, but it is an honor to introduce you. And I want to give a little description about this doctor I'm going to present here. Dr. Cherese Winstead, sorry. She is a PhD-trained chemist from the Virginia Tech University. She is an associate professor at Delaware State University, and she holds the prestigious honor of being the dean of the College of Agriculture, Science, and Technology. Previously, she was the chair of the Department of Chemistry, where she still holds that beautiful title of professor and leadership. Since joining Delaware State University in 2008, she has transformed strides in research. She's been successful to secure and manage over $60 million in funding as a principal investigator. And her work reflects her strong interdisciplinary approach with collaboration and research and education, particularly in STEM. And that is something that being a professor in nursing is a great representation. In her research and scholarly activities, Dr. Winstead has engaged in community-based organizations. Her affiliations are with the Delaware Prosperity Partnership, NASA Space Grant, and one that I am particularly involved with, Nemours, Delaware Comprehensive Sickle Cell Research Center. Beyond academia, Dr. Winstead has demonstrated a lifelong commitment to science and STEM, not only to Delaware State University students, but to high school students and those like-minded. She is a founder and president of the Young Chemist Society and Helping Young People Exceed, which are nonprofit organizations that she's held the title for over 2 decades. Her national leadership has further been recognized by President Joe Biden, in which she has served 2 terms and been appointed to hold this honor of being the one who represents the National Medal of Science Committee leader. For those who don't know what this committee represents, it actually presents an honor, prestigious award with the United States to scientists and engineers who want to do exceptional work and contribution in the world of STEM. Through her scholarship and leadership, mentorship, and service, not only at Delaware State University, but as a great representative and monumental through the state of Delaware, she continues to shape the future of science, education, leadership, and innovation within STEM. It is a great honor and privilege to introduce Dr. Cherese Winstead.
Wow, the way Bianca read that, I was like, who is she talking about? Well, thank you so much, and it is my esteemed pleasure here just to talk about the impact that this body of folks have had on Delaware State University and our partnership with ACCEL. Myself, I am a personal story of what that looks like for a young junior faculty member at Delaware State University. Of course, ACCEL really goes beyond faculty, staff, and students. But as a young professor in chemistry, to say no least, sometimes we're stuck in our traditional disciplines, and it's hard to show students what that community engagement of basic research actually looks like. And so as a young professor, I was tapped on the shoulder for a phenomenal opportunity to take my research. And at the time, we were just looking at nanofibers. And my chair at the time, Dr. Kimmich, said, listen, have you thought about using your nanofibers for the proliferation of stem cells? I had no idea. Literally, as a chemist, I am trained just to think about the chemistry composition. And when he talked about even CD34 and sickle cell, I myself, as a member of the demographic of folks that actually impacts, I did not understand fully what this looks like for our students and for our community and beyond. So in my first year, I was thrust into this world of going from basic research to clinical and translational research. And instantly, our students were engaged. What they saw as a traditional chemistry laboratory now is doing sickle cell research. And I just want to give you that example of what that looks like, of interactions with nurses, mentors. And as a young professor, I still have these folks today. They're still on my cell phone. I can reach out to them for everything. Rob Akins, like those types of relationships within the ACCEL mentorship community is phenomenal, and it has always grown. So that was back in 2008, and now fast forward, now I'm also embracing and introducing students to what this looks like with community engaged research. So our students now understand what sickle cell means to our community. They interact with nurses, they interact with doctors and medical practitioners. They understand what basic research and what that looks like to the everyday student. And I know we all think about our students and we say, oh, you know, they're all digitally inclined, they're always on their cell phones, and they are. This Generation Alpha is what they call them. Perfect. Okay, perfect. But they're socially conscious, right? So even though we say they're digitally focused, they want to use the digital technologies for socially conscious impact. And so that's why the research with Susan and Dr. Shi over at University of Delaware is so very important, because it allows students to go into the space of where they are, which is digitally innovation, and then talk about how that can impact community engaged research. So I'm really excited to even introduce our panelists here that will be talking about essentially what this looks like for community engaged research. The next voice that you'll hear is that coming from Dr. Eva Obrusnikova. She's a full professor in the Department of Health, Behavior, and Nutrition Sciences at the University of Delaware, where she directs the Health and Disability Laboratory. Her research focuses on promoting physical activity and reducing health disparities among individuals with intellectual and developmental disabilities through community-based interventions, adapted program design, and technology-enhanced approaches. She has developed and validated innovative tools such as the exercise self-efficacy for adults with intellectual disability scale, and has led numerous federally and foundation-funded projects advancing adapted physical activity. So without further ado, the next voice you'll hear is that from Dr. Obrusnikova.
Good morning, or if I can say it's morning, it's almost noon. And thank you for having us. Here we go. As you can see, I'm not presenting alone. My name is Eva Obrusnikova from the University of Delaware, presenting with Cora Firkin, who is currently at Lincoln University and is my former doctoral student. We will share Delaware Park accessibility audit findings in our next step, the PACE program. First, I'll present some statistics. Nationally, just under 14% of people report having a disability. This is not a small group, and it frames why accessibility is a public health priority. In Delaware, the rate is slightly higher, around 14%, not that much, with a greater concentration in Newcastle and Sussex counties. Disability prevalence rises sharply with age and is present across all racial and ethnic groups. Slightly higher rates are evident among Black and white residents. People with disabilities clearly represent a significant segment of our community. Disability is associated with high healthcare expenditures. In Delaware, costs reach $3.1 billion, about a third of all healthcare spending. That averages nearly $21,000 per person with a disability per year. At the same time, people with disabilities face persistent disparities in employment and income, which even more widen inequities. They also face higher rates of depression, and, obesity, and smoking, and about 40% are not meeting physical activity guidelines. This is why inclusive community spaces are, and programs are very important. Our work builds on James Rimmer's model linking access, design, and adherence to health outcomes. Parks and playgrounds can be powerful community spaces, but only if they go beyond minimum standards. Adherence supports like inclusive, individualized programs, behavioral supports, and affordability, and also clear communication are what translate access into real health impact. For the purpose of this presentation, I'll quickly identify the standards. ADA accessibility guidelines set minimum facility standards, such as routes, parking, restrooms, signage. And PROAC extends these into the public rights of way, including sidewalks, curb ramps, and transit. But we promote, in our programs, we promote universal design, creating spaces usable for all ages and abilities, reducing stigma, and supporting long-term inclusion. So what did we do? Building on our 2023 Newcastle pilot published in the Delaware Journal of Public Health in summer 2024, we completed a stratified audit of 50 free access public parks with playgrounds. Our aim was to evaluate accessibility, usability, and safety to guide equity-focused improvements. We excluded unsafe or fee-based sites, including Delaware state parks. We used two validated tools, the Community Health Inclusion Index, which evaluates access, amenities, and communication against the accessibility standards that I just mentioned, and also the Playground Safety Report Card, evaluating safety and life-threatening risks. Our stratified sample included 28 sites in Newcastle, 10 in Kent, and 12 in Sussex counties, selected based on population density within each zip code. This also captured diverse contexts, Newcastle being more racially diverse, and Kent having the highest disability percentage, and Sussex with many older adults living with a disability. Here are the results. Most parks had the basics. Nearly 90% had parking lots. That's a high number. 70 to 80% had compliant crossing and curb ramps, and about 2/3 had designated accessible parking. So many sites met ADA's and PROAC standards. However, major gaps existed. 70% of parks had no transit stop nearby. That's a large number when people cannot access the park. especially if they're in a wheelchair. More than half of curb ramps lacked warning surfaces. Crossing aids like auditory signals and countdowns were almost absent, and only a third had a van-accessible parking. Clearly, there were many barriers for people with disabilities to enter the parks. On site, parks offered strong environmental amenities. Most had green spaces, shade, safe walking conditions, and clean, quiet environments. Pathways were often wide, smooth, and obstacle-free, encouraging physical activity. Yet, key usability challenges stood out, more actually than in the previous slide that I showed you, or previous gaps. Restrooms often lacked wide stalls, grab bars, or automatic doors. Trails and play spaces were uneven and under-equipped, with few or unusable benches. Navigation was nearly absent, and most parks had no trail aids or maps. So again, amenities existed, but their usability was very limited. Communication was one of the weakest areas. Less than 15% of parks had pictograms or large print signage. Electronic text and disability representation were almost non-existent. Without these, families with diverse needs cannot easily access or navigate the spaces. The two pictures on the bottom, on your left, are pictures from Delaware State Park. So these exist in Delaware, but are limited to parks with fees, where you have to pay to enter. Playground safety was generally strong, as evident in this chart. That made me feel better because I have a young child, 4-year-old child. Most sites had compliant surfacing, safe equipment heights, no major gaps, and clear visibility for supervision. Clearly, safety was playground's design priority. Similar to parks, there were gaps. Not many, but there were gaps that are easy to fix. Loose fill surfacing was often shallow or littered with debris. Few playgrounds posted rules or had signage separating equipment by age. And county differences were noticeable. Kent scored the best, Newcastle lowest, including the only park that flagged at risk. In summary, many Delaware parks meet ADA standards, but real gaps, especially in transit, curb ramps, restrooms, trails, and communication, limit their use. Also, compliance isn't inclusion. Amenities exist, but usability still lacks, doesn't guarantee inclusion. Based on demographics, the 3 counties have different needs. Sussex needs more mobility and age-friendly designs. Newcastle needs culturally responsive, multilingual communication systems. Kent needs rural accessible solutions. Given these needs, rather than investing in siloed disability-focused programs, we feel that we should invest in universal evidence-based solutions for all. To close the gap, we need to move from compliance to action. We need to fix foundations, maintain amenities, improve communication, design programs for adherence, and measure its impact. Our next step is to implement a new program titled Promoting Active Community Engagement, or PACE, with the aim to provide adherence supports that help adults with intellectual and developmental disabilities and their caregivers participate meaningfully and consistently in community parks and playgrounds. The PACE links our audit findings to inclusive, individualized sessions, utilizing physical activities such as walking, rolling, stretching, even biking, led by trained student facilitators and supported by objective measures such as step counts, heart rate, GPS, cardio response cards. And we piloted these protocols in spring 2025 and plan to conduct multi-site pilot in 2026. We'll track attendance, physical activity levels, safety, and perceived access and competence, aiming for participants to spend at least 70% of cardio session time in a moderate intensity zone, which is the biggest challenge, to put effort into exercise, not just walk in the parks, but also walk at a particular pace. We will return results to partners to guide improvements and scale as funding and partnerships grow. And that's all from me. Thank you very much. I welcome questions.
Thank you very much. We have time for one question from the audience.
Very fast.
Any questions? Oh.
So there's a huge connection between physical activity and health. And I'm wondering if there's a connection between some of the physical activity programs like PACE and the Walk with Ease, Walk and Roll that the university's doing through the cooperative extension. Have you guys?
We're doing this separately, so that is something definitely that can be combined. But
It's a wonderful conversation to open.
yeah, absolutely. But I think it always starts with the environment. We need to look at the environment also, because it's wonderful to create an intervention or to have a strategy, but without implementing it in the setting, because what we're finding in our, when implementing this, that people are not going to come to us. They want to be in their communities, in their neighborhoods. So we need to make sure that their neighborhoods are safe to walk, because having a life-threatening playground to go to is not something I would, as a University of Delaware employee, want to promote. So we need to start with the environment, with the parks, so that they feel comfortable walking there.
Thank you very much. I'm going to hand it back over to Dr. Winstead to introduce our next presenter.
Thanks so much. All right. Make sure we got the right one. All right. So next we have Dr. Abbas Zaidi, who is an assistant professor at Thomas Jefferson University and the medical director of outpatient cardiology at Nemours Children's Health in Wilmington, Delaware. Dr. Zaidi's interests are improving healthcare systems and access for diverse patients and families. Dr. Zaidi incorporates concepts of population health, implementation science, and social determinants of health into his clinical and research endeavors. He has received funding through Mentored Research Development Awards, MRDA from ACCEL, and recently received a grant to address gaps in care for adult congenital heart disease patients for the 2025-2026 Collaborative Award for Population Health through Thomas Jefferson University College of Population Health. So Dr. Abbas Zaidi, we look forward to hearing your talk. Thank you so much.
Thank you so much for having me here today, and it's such an honor to be here. I'll be talking about my research on pediatric hypertension and how we use the learning health systems approach and how partnerships within the state of Delaware really helped for us to conduct this work. These are my disclosures for the research that I'll be presenting. So I have three main goals for today. One is to talk about pediatric hypertension and why it matters and what's the scope and challenges of dealing with a chronic disease like this within the state of Delaware, and then how we developed a multi-stakeholder ecosystem and how these partnerships and roles really advance the research and will help us moving forward. And then I'll leave with some recommendations on how to think about managing chronic diseases and just sort of my experience on doing this within Delaware. So starting with some basic background, high blood pressure is more common than you might think in kids. 5% of children actually have diagnosed hypertension, and 10 to 15% of adolescents have elevated blood pressure. And hypertension in childhood leads to hypertension in adulthood. Many of you may know it causes organ damage, but the main challenge is that only less than 25% of children are actually getting diagnosed with this issue. So it's a much larger health system problem. And when we started looking at data from the state of Delaware, we looked at more than 90,000 outpatient clinic visits. And what we found is that if you looked at blood pressures documented within the chart, up to 5% of children had hypertension, but the diagnostic rate within the state of Delaware was only 0.9%. So there was clearly a gap there. And then out of the kids who were diagnosed, 75% of them were not coming back for routine follow-up. So there were significant gaps in diagnosis management, and there was a need for improving our system. But more importantly, it was really important to understand why this was happening. So this is why we took a learning health systems approach, where we started to really talk to people, and started by talking to the clients, caregivers, communities, started partnering with primary care teams, clinicians, and providers, and also engaged with the system level partners, researchers, and funders to identify the questions and opportunities for change, and then use those to inform data and answer some of those questions, and then implement those learnings across all of the systems. So the way I think about a learning health system is it's sort of like a co-production of healthcare, where you're bringing perspectives from all the partners together to improve the healthcare delivery. And these partnerships really kind of helped me, sort of do this research, starting off with my learning health systems training that was through PedsNet and through Nemours. Omar Khan, who's here, who's been a great mentor and guided me throughout the project. University of Delaware, Ben helped us with the biostats. I was able to get my QIP certification and master's through Jefferson, and then I was one of the MRDA recipients through the Delaware CTR. So as you can see, so many people have helped me along the journey to do this work. So the way we kind of thought about how this learning health systems approach is going to inform value is by first developing a community of interest to clarify some of the problems through shared decision making, and then taking action through QI and research, so we can transform the data to knowledge, knowledge to practice. And then as we go through this cycle, we're actually incorporating feedback directly from patients and providers. So that's in itself improving value and leads to better population value, and hopefully will lead to reduced cost. And the approach we took for health equity was to think about it from the get-go, like think about it at all stages of our project, and move beyond just looking at the patient's individual social needs, but also to incorporate some social norms of health factors and really think about where the patient's living, what's the neighborhood conditions like. So our three goals were, one was to identify the barriers and facilitators to incorporation of hypertension detection guidelines. The second was to develop a toolkit of implementation strategies, and then to test out the feasibility and acceptability of these strategies. We used implementation science frameworks. I'm not going to go through this whole slide to describe the whole process behind it, but just to give you a sense of how we did that, we used these frameworks to devise our interview questions by using the domains and constructs that they have. To be very focused in what kind of information we wanted to get from the families and the providers. Then we went through a qualitative iterative process to develop the codes and eventually the themes. And then we also incorporated social norms of health factors by using Child Opportunity Index, which is an index which indicates neighborhood conditions in several domains, to make sure we have a very representative population that we were interviewing, and also made sure we had racial, ethnic diversity, and included Spanish-speaking families as we interviewed them. We also did interviews with 25 providers across Delaware and Pennsylvania, providers who work at Nemours, but then used COI and gaps in care to also identify these practices so that we do targeted interviews. So here are some of the findings from our research. This was published last year, where we started to talk to parent and providers about their perceptions on pediatric hypertension. What we found is that families are coming into clinic knowing a lot about adult hypertension because of their own personal experiences or family history, but as soon as they start interacting with the healthcare system, there are competing factors. Health systems are challenging. We're not making it a priority, or we attribute high blood pressure to anxiety or white coat and have reservations on using medications in children ourselves. So when that interaction happens, parents know about adult hypertension, but they don't get really concerned when they see high blood pressure in their child, and they're not wanting medications. And that's one of the reasons why they don't ask questions, and there's lack of follow-up that we initially saw. This is a study that was published this year where we talked to families about like what are the main challenges of why you're having difficulty coming back, and what are some of the recommendations that you may have. So families talked a lot about social numbers of health factors. As you can imagine, with multiple blood pressure checks needed coming back to clinic, they're losing money each time they do that. And there's also insurance and cost to care, and also the kid leaving school. And when they start interacting with the healthcare system, there's lack of resources, time constraints. So all of that combined together, families really are advocating for clear communication, flexible scheduling, having telehealth options, and then being able to check the blood pressure outside of the confines of the clinic, like maybe at home or at school, so that the kid doesn't leave the school, and then having stronger care coordination is sort of some of the recommendations that came out of this work. And this is work that's under review right now for publication, but we also asked providers on how best can we support the healthcare system from within, and they talked about making the guidelines, which are quite complex and cumbersome, easier, and making them standard across various offices and systems, and making them more role-specific so that the MAs, nurses, and MDs have like very role-specific guidelines, and having collaborations with specialists like myself. More education and training, so not just like a one-time course, but ongoing training, specialized skills training, because blood pressure measurement itself can be quite complex in kids, as many of you know, and then tools for learning for them. And better EMR changes, such as better visualizations or improving alert systems, or systems that can provide a complete overview. As you know, it's so clunky to go through the EMR to dig up all of the old blood pressures for the child through the EMR. Better equipment and infrastructure, so reliable tools that work and go through regular upgrades. And then care coordination, so that there's teams that can follow up on the patients and coordinate blood pressures happening outside of the confines of clinics, such as at school or at home. And one statement that I just wanted to share with what the family said was education, notification, and follow-up. So tell me what it is, not just glossing over it. Explain to me what it means, and then follow up if you do not see me there. So just overall better healthcare systems. In addition, we had a community engagement award led by Yvette Santiago and her team at Nemours, and we were able to do a lot of community engagement by talking to families and understanding what their perceptions are, what their barriers are of blood pressure, and do a lot of screening. This is one example that was led by Jennifer Higgins, where we went out into the community who was affected by closures closing, and lots of kids who did not have health care, to kind of help support them. And since then, we've done a bunch of these sort of community events to try to engage with the families, understand what's going on with them, educate them about pediatric hypertension. And some of the survey data that we're getting is also interesting in that, families are finding it challenging to prepare meals. About 40% of families said that to us. It's hard when healthy food is expensive. So families are saying that, that's definitely a challenge. Not having enough space to exercise, and just finding it difficult because of busy schedules is an ongoing issue that families deal with. And then just doing simple interventions like talking to them improved their understanding of pediatric hypertension, and they knew what sort of lifestyle changes to make, and for example, how much salt to eat, that. So my recommendations, or things that I've learned myself, is to just be collaborative. This whole forum right now is such a great example of that, how we all can just, work together by co-designing solutions, and especially involving the parents and diverse families and incorporating their perspective to build trust and transparency into any project that we're doing, and using some kind of approach such as, population health approach, COI, whatever framework that's available, accessible, that someone in your team can conduct and can really help kind of refine and make the whole project better. And then engaging with the community. So reaching out, going outside of the confines of the clinic, going out in the community, talking to people in schools, churches, local organizations, to make sure your interventions are cultural and linguistically tailored. And at the same time, there's a desperate need, and we all know that we need to redesign the healthcare system. And we need to not just do it within by standardizing clinical pathways and EMRs, but also incorporating what's happening outside of the confines of the clinic and integrating that within the healthcare delivery model, such as blood pressure measurements or home BP monitoring into the care models. And I just would like to thank all of these organizations and everyone who's helped me along on this journey. And if you have any questions, please reach out. Thank you.
Thank you, Dr. Zaidi. We have time for one question from the audience.
Thank you, Dr. Zaidi. That was really powerful. I think as you noted, most children who have undiagnosed hypertension aren't having that picked up in their pediatrician's or family physician's office. And you mentioned the role of community. We have a very robust school-based health center program in Delaware. Are there opportunities for partnership, including on community-based research, with that group so we could pick kids up at the point of care and then have them referred to experts such as yourself?
Absolutely, yeah. So I think, when we started to talk to families, that was one of the things that they highlighted, that just having the kid leave the school and for them to drive over to just get a blood pressure check in clinic is just so cumbersome and costly for them. So they really advocated for us to make ways and develop these partnerships to kind of get the hypertension detection piece done. And yes, there's definitely ways to do that. Like, we are currently in the process of obtaining some funding to partner with the Delaware School Nursing Alliance. And I know your team is involved from Christiana Care. Our school-based health system team is involved. So we're trying to figure out ways so that we can develop sort of this one team who gets the job done on the ground. Definitely. Thank you for the question.
All right, so next we have Dr. Phan. And Dr. Phan is an associate professor of pediatrics at Thomas Jefferson University and medical director of the Nemours Healthy Weight and Wellness Clinic. In this role, she leads a multidisciplinary team providing comprehensive obesity care to nearly 4,000 children across the Delaware Valley. A senior research scientist at the Nemours Center for Healthcare Delivery Science, Dr. Phan has received continuous NIH funding for over a decade. Her research focuses on psychosocial factors contributing to disparities in childhood obesity outcomes using community-engaged and technology-enhanced methods. So without further ado, we will have, the next voice you'll hear is that of Dr. Phan.
All right. Hi, everyone. So it's really hard because I know I'm standing in between everyone here and lunch, but I appreciate so much this opportunity to speak to you about a project that's like a little pet project of mine, but I think really highlights how engaging early with community partners can really transform a research study. This project was funded by the REACH Center at Nemours, which is an NIH-funded Center of Biomedical Research Excellence. Although I do have to say, I just want to put a plug in and say that, like a lot of the other speakers, I've been supported by ACCEL over the years with 2 MRDAs, as well as 2 pilots, and so I really thank them as well for their support of my career and my career development. So as a brief background, obesity rates in children continue to rise despite decades of working to try to reverse this trend. And we know that the problem just got worse with the pandemic. Currently, more than 1 in 5 children in the US have obesity, and there are clear disparities driven by complex socio-ecological factors, with nearly 1 in 4 children from Black and Hispanic communities and communities with fewer resources having obesity. This leads to disparities in health outcomes, not just related to conditions like hypertension, cardiovascular disease, diabetes, but also, I think, importantly related to a child's mental health and psychosocial functioning. Because of this, the AAP recommends that children with obesity receive comprehensive, evidence-based, interdisciplinary treatment. And we actually have a team that provides this in Delaware, putting in a shameless plug for the amazing team of medical providers, psychologists, dietitians, and exercise physiologists that I work with at the Nemours Healthy Weight and Wellness Clinic. But we know that access is an issue. And this is especially the case for children in southern Delaware who live more than 2 hours from our clinic in Wilmington, which you can see with the little red apple. When we looked at the data, less than 20% of young children with obesity receiving care at one of our primary clinics in Seaford, Milford, and Millsboro were referred to our clinic, and less than 10% ended up having a visit. Hispanic children were less likely to be referred. So the major goal of this project was to improve access to obesity care for families in Southern Delaware. But we knew to do that, we'd have to refine the care model to ensure that it aligned with the resources, strengths, and values of the community. And to do that, we knew that partnership was critical. So we met routinely throughout the course of the entire project, from start to finish, with 3 sets of stakeholders. The first was a group of medical providers and care coordinators at each of the 3 primary care clinics in Southern Delaware. The second was a group of what ended up being primarily Latina mothers of children with obesity from Southern Delaware. And the third group were representatives from the community organizations listed here: Sussex County Health Coalition, Boys and Girls Club of Delaware, the YMCA of Delaware, Children's and Families First Delaware, and then we did have representation as well from the PANO program with DHSS. At one of our first meetings with the community partners, we presented the initial concept for our care model: visits with our healthy weight and wellness team, as well as visits with the community health worker, and healthy lifestyle resources, all through a mobile app. But after the first meeting, we realized that that wasn't enough. We realized that the best way to build rapport with families in Southern Delaware was to be in person. And we realized that we needed to promote healthy lifestyles outside of the clinical setting and out in the community. We realized we needed to make sure we were addressing any social needs that families might have. And a shout out here to the 2 community health workers, Wanda Flores and Letitia Tolbert, and the 2 research coordinators, Alejandra Perez Ramirez and Kelsey Higgins, who were instrumental in helping families to navigate their care during this project. And so the resulting care model was truly an integration of both healthcare and community care. As I mentioned, one thing that came across clearly in our discussion with community partners was that they felt that there needed to be a way to promote healthy lifestyles out in the community. So I'm going to spotlight here how we accomplished this in this study. During one of the first meetings, Suchi from Boys and Girls Club and Midleen from Children's and Families First had a great idea, which, if you know these 2 amazing women, you know that connecting the dots is sort of what they do best. And they said, hey, we already have a program in Southern Delaware called our Dollar Dinner, where we provide a nutritious meal to families for just $1 per person at the local Boys and Girls Club. Why don't we leverage that? And so we got creative. We moved around some research money to support the cook volunteering her time at the Dollar Dinners and to bring fitness instructors to the event. You can see here some families doing yoga at one of the events. And we advertised the Dollar Dinner to our families as a component of our care model. You'll notice that one of the ways we promoted the Dollar Dinner was through a mobile app notification. And we did develop a mobile app still as part of this research study to help families track healthy lifestyle goals, access healthy lifestyle resources, as you can see in these screenshots. One important thing we did was conduct in-depth testing of the app with families of children with obesity, incorporating their feedback so it would be more user-friendly, which is another way of making sure that you're hearing the voices of families when you're creating an intervention. In the interest of time, I won't be describing this process, but the paper describing it is linked here for those who are interested. Once we had a care model in place, we tested it in a pilot randomized controlled trial. We recruited families of children 4 to 12 years of age with obesity from Southern Delaware and randomized them to either receive the healthy lifestyle care model that we had created with the input from our community partners, or an active control group who received standard of care at their primary care offices. They received the intervention or standard of care for 6 months, and we measured changes in BMI percentile, days in study, and attrition as our primary outcomes. We ended up enrolling 59 families of diverse backgrounds, including 36% Black, 27% Hispanic, and 37% white families. 20% of the caregivers enrolled were Spanish-speaking, and 76% of our families had public insurance. While we did see a trend in that participants in the healthy lifestyle group on average lost weight, whereas those in the standard care group gained weight, we didn't achieve a sample size, unfortunately, large enough to detect a significant difference. But we did find that Hispanic families who were more engaged, if they were receiving the healthy lifestyle care model, they actually stayed nearly 100 days longer in the study if they were in that group. Finally, we conducted exit interviews with 21 of the families who completed the healthy lifestyle care model, which I think is another important way of making sure that the voices of families are heard in research. And their words showed an appreciation for the way that the care model addressed the psychosocial needs of families and the importance of the rapport families built with the care team. This is just a snippet of the quotes from the interviews. If I have some time, I'm going to read one or two just because I think they really sort of sum up sort of what this project ended up really being about. One Latina mother said, "I signed up because I wanted to motivate my son to increase his self-esteem. And also when they said that they were going to give help for losing weight the right way, it caught my attention. It motivated us too, especially me. It helped me focus on helping my son in the process and being more connected to him." And then one more as I'm looking at my moderator. One Latina mother said, "Getting my children to eat vegetables. That's something that I struggled with a lot." I think we all can relate to that. But the nights really motivated them because they saw the food that was there and they wanted to eat the same. And that's what I liked the most for them. They learned to eat the things that they didn't like before, and now they do like it. So what's next? We'll actually be presenting this study in a month at Obesity Week, which is a conference held in Atlanta, Georgia this year. And I'm really happy to report that, I think one of the things is translating research to clinical practice, and I have the benefit of kind of playing dual roles. And so as a result, in large part of this study, we kind of took our findings there, the need for in-person visits that we heard from families and our community partners, and we actually started providing care down in Milford, starting in February 2025. And actually, the psychologist and the dietitian who were part of our interdisciplinary clinical team for this study ended up being the psychologist and dietitian that we put down in Milford, who are now providing care to families in Milford and Sussex County. Given the success of the care model with Hispanic families, we're now working on tailoring it even further to address the psychosocial needs of Hispanic families. And you can see here that I'm not saying healthy lifestyles necessarily, although that's a part of it. But we really felt that what we had developed, again, with community partner input, is a care model that really addresses psychosocial needs and the need for connection and community. And so we're working on finding innovative funding sources. A lot of our community partners, when we met with them last, said, maybe NIH is not the right place for this right now. Maybe look out into the community to find some good funding sources. And so that's what we're working on doing. So this project really took a village. You can see here all the people that were involved, and I'm sure I've forgotten some. I'd like to thank my research team and collaborators at Nemours, but especially the partners highlighted in the blue box for their time and valuable insights that truly made this project a success. Thanks.
Thank you very much. We have time for one question. I'll ask a quick question. Funding for community health workers. I know you've used community health workers in a few of your research projects, and we talked about hopefully funding from Medicaid coming down the road. Have you considered that as one of your potential future funding sources for sustainability?
Yeah, I heard that, and I'm really excited about the potential for that, as well as all the food as medicine funding that might be coming up to help sustain these initiatives. I think, it's really hard to find these little pockets of money, but we know that there are certain things that work, like community health workers, like good nutrition and nutrition programs. I think my pilot project was just a small example of that. And so I'm really excited about all the enthusiasm to help support this type of work in the future, and happy to collaborate with anybody who wants to collaborate.
Great, thank you
Thanks so
very
much.
much. And I'm going to hand it. I'm going to hand it over to Gwen Angelette and David Chen.
Everybody hear me okay? I have an inside voice. That's why I want to make sure this mic works. First of all, I think we want to give our panelists from this last panel, and actually all of our panelists, and all of our speakers today, a really rousing round of applause. I am the chair of the Community Advisory Council for the ACCEL Community Engagement and Outreach Core. I've had the pleasure of being a part of this entity, if you will, for a very long time. And I've seen the evolution of this work. When I started coming to these conferences many years ago, you never heard community come out so much. But today it really made my heart feel good that what we've been doing is working. And it's been a joint community research partnership, if you will. We've been helping each other. We've been building each other's capacity. And that's really what the Community Advisory Council is about. It's really being that voice in the room when the planning's taking place, when research is being talked about, where gaps are being identified, to say, here, we need to think about this in this way. Maybe we should talk to those people, helping make those connections, helping build that trust, helping solve the barriers that come up. Some barriers we have a little harder time solving, like the ones around funding, but we work on that too. And so today is really a wonderful culmination of all of those events. I'd like to just recognize our Community Advisory Council members that are still able to be with us today. If you would stand. Anyone still? Thank you, Alta. And I see Lubeda's in the very back there. Thank you for being with us. And the ultimate in community engagement today is our Community Choice Awards. And I'd like to turn it over to my partner, David Chen, to talk more about that.
Thank you all for voting. Our tallies as of 11:41. We have a first place, a second place, and then a four-way tie for third place. I only have certificates enough for first and second, and I will provide the others later. So for first place, we have, drum roll, Food is Medicine, Effectiveness of Delaware's Feeding Families, to John Oluwadero. John, are you here? Strong work. All right. And second place, Brain Health Champions, Building Brain Healthy Communities in Delaware, Olivia Dallas. Congratulations. Well done. And I'm going to read out the names for the multi-way tie for third place, if you could rise to be acknowledged. Alzheimer's Disease Research, Faith Stagg. Community Health Worker-Led Coaching, Ashley Viscardi. Future Planning and Wellbeing for Individuals with Intellectual Disabilities, Krista Thompson. And Closing the Gap, Cancer Screening Navigation and Primary Care, Heather Bittner-Fagan and Ross Budziszewski. Thank you, thank you.
Okay, we're so close to lunch. I promise I'm the last speaker. A few thank yous. First to Christiana Care for giving us this wonderful event space. Thank you so much to the exhibitors who will still be out there during lunch. The leadership from the Puerto Rico CTR is here with us today. Dr. Edna Acosta, Laura Domenech, and Luisa Morales. Thank you for coming so far to attend this conference and be speakers. In addition to the planning committee members who you've heard from today, there are also people who have really supported this behind the scenes. So Missy Bollinger from Christiana,
Karen Hoff from University of Delaware, and I cannot thank enough Lacey Long and Karen Wilkinson. Please stand so we can give you a round of applause. So they are conference managers, from assembling the CME, the presenter logistics, the emails, the food, to the pumpkins and the flowers on the tables, everything. Thank you so much. We couldn't have done it without you. Thank you all for being here. A reminder, CME and QR codes for the program surveys. Please complete the program surveys. The last thing I wanted to mention is just instructions for the workshop assignments. Check the front of your name tag for the workshop assignments. They're numbered 1 and 2. The number 1 is the workshop that you go to during the 12:30 to 1:30 hour, and then the number 2 is the one you would go to from 1:40 to 2:40. And just as a clarification, the pink sticker is referring to the data science workshop, which will be in this room. The purple sticker is measuring program impact. So just since the colors do not completely match. If you have any questions, please ask any of us. Feel free to grab box lunches outside, and we hope you'll stay with us for the afternoon workshops. Thank you.